Question 1. Topic: Burn management. A 45-year-old male presents with second and third degree burns covering approximately 35% of his total body surface area to BSA after a workplace accident involving hot liquid. He is hemodynamically stable but reports significant pain. As part of his initial management, what is the most appropriate next step? A. Administer intravenous fluids based on the Parkland formula. B. Perform immediate escherotomy on all affected areas. C. Apply topical antibiotics and observe for signs of infection before deciding on fluid resuscitation. D. Intubate the patient immediately, even in the absence of airway compromise. Answer A. Administer intravenous fluids based on the Parkland formula. Explanation: the Parkland formula is used to guide fluid resuscitation in burn patients. 4 ml x body weight kg x percent EBSA bowels toll fluids over 24 hours. Half is administered in the first 8 hours and the rest over the next 16 hours. Adequate fluid resuscitation is crucial to prevent hypovolemic shock due to capillary leakage and fluid loss. B. Incorrect. Escherotomy is only indicated if there are signs of compartment syndrome or compromised circulation. C. Incorrect. While topical antibiotics are used to prevent infection, delaying fluid resuscitation can lead to multi-organ failure. D. Incorrect. Prophylactic intubation is unnecessary unless there are signs of air compromise, e.g., inhalation injury, stridor, or progressive hoarseness. Guideline reference: American Burn Association (ABA). Guidelines recommend aggressive fluid resuscitation in burns exceeding 20% EBSA. Question 2. Topic: Hand surgery. Nerve repair and tendon reconstruction. A 30-year-old construction worker suffers a deep laceration to his forearm from a power tool. Upon examination, he is unable to flex his index and middle fingers at the proximal interphalangeal pec joints. Additionally, he has numbness over the lateral palm and first 3 digits. Which structure is most likely injured? A. Ulnar nerve. B. Radial nerve. C. Median nerve. D. Flexor carpi radialis tendon. Answer: C. Median nerve. Explanation: the median nerve innervates the flexor digitorum superficialis, which is responsible for flexing the index and middle fingers at the pec joints. Additionally, it provides sensory innervation to the lateral palm and first 3 digits. Injury to this nerve leads to weakness in finger flexion and sensory loss in the median nerve distribution. A. Incorrect. The ulnar nerve primarily affects the ring and little fingers and causes cawing of these fingers when injured. B. Incorrect. The radial nerve controls wrist and finger extension. Injury to this nerve would cause wrist drop, not an inability to flex fingers. D. Incorrect. The flexor carpi radialis tendon is involved in wrist flexion but does not explain the sensory loss. Guideline reference: the American Society for Surgery of the Hand guidelines state that high median nerve injuries can cause both motor and sensory deficits in the forearm and hand. Question 3. Scenario-based. Topic: breast reconstruction. Implant-based versus autologous. Dr. Mitchell, a plastic surgeon, is consulting with Ms. Thompson, a 50-year-old woman who has undergone a bilateral mastectomy due to breast cancer. Ms. Thompson is interested in breast reconstruction but is unsure whether she should choose implant-based or autologous tissue reconstruction. She has a history of radiation therapy and a ER32. Which of the following options is the most appropriate recommendation for Ms. Thompson's breast reconstruction? A. Implant-based reconstruction, as it is the standard first-line option for all post-mastectomy patients. B. Autologous tissue reconstruction, e.g., deep flap. Due to her history of radiation therapy. C. Forego reconstruction entirely, as her BMI is contraindication for surgery. D. Perform an immediate implant-based reconstruction without discussing autologous options. Answer B. Autologous tissue reconstruction, e.g., deep flap. Due to her history of radiation therapy. Explanation: patients with a history of radiation therapy have a significantly higher risk of complications with implant-based reconstruction, including capsular contracture, infection, and poor aesthetic outcomes. In such cases, autologous tissue reconstruction, such as the deep flap, is preferred as it provides a more durable and natural result. Better long-term outcomes. A. Incorrect. While implant-based reconstruction is a common option, it is not always first line, particularly in patients who have had radiation. C. Incorrect. A BR32 is not an absolute contraindication for reconstruction. However, it may require additional considerations such as staged procedures or preoperative weight loss counseling. D. Incorrect. Patients should be informed of all reconstructive options, including the and benefits of each. Immediate implant placement in a radiated field can result in poor outcomes. Guideline reference: the American Society of Plastic Surgeons (ASPS) guidelines state that autologous breast reconstruction is preferred in patients with a history of radiation therapy, as it results in lower complication rates compared to implants in these cases. Question 4. Topic: Wound healing and reconstruction. A 45-year-old patient presents with a chronic non-healing wound on the lower leg following a traumatic injury 10 weeks ago. The wound has irregular borders, areas of granulation tissue, and evidence of biofilm formation. Cultures reveal a polymicrobial infection with mold drug-resistant bacteria. The patient has diabetes and peripheral vascular disease. Despite standard wound, including debridement and antibiotics, the wound has not improved. What is the most appropriate next step in management? A. Continue standard wound care with local wound dressings and empirical antibiotics. B. Perform a surgical debridement followed by application of a vacuum-assisted closure VAC device. C. Use hyperbaric oxygen therapy as the primary treatment to promote wound healing. D. Apply a full-thickness skin graft immediately to cover the wound and prevent further infection. Answer: B. Perform a surgical debridement followed by application of a vacuum-assisted closure VAC device. Explanation: chronic non-healing wounds often develop biofilms that impair healing and reduce antibiotic efficacy. In patients with comorbidities like diabetes and peripheral vascular disease, aggressive debridement is crucial to remove necrotic tissue and bacterial biofilms. Vacuum-assisted closure VAC therapy promotes granular tissue formation, decreases edema, and improves local perfusion, making it an effective option before definitive reconstruction. Option is incorrect. Standard wound care alone is insufficient due to the presence of biofilm and chronicity of the wound. Option C incorrect. Hyperbaric oxygen therapy may be beneficial but is not the primary treatment. It is typically used as an adjunct for refractory wounds. Option D incorrect. Immediate skin grafting is inappropriate in the setting of active infection and inadequate wound bed preparation. Relevant guidelines: the Wound Healing Society recommends debridement and advanced wound therapy. G. VAC for chronic wounds before considering definitive closure. ITA guidelines for diabetic foot infections emphasize wound debridement and targeted antibiotic therapy. Question 5. Topic: breast aesthetic surgery. A 32-year-old woman with no significant medical history presents for consultation regarding breast augmentation. She is a non-smoker, has a ER of 23, and desires a natural-appearing breast augmentation with silicone implants. During the consultation, she expresses concern about potential complications, including capsular contracture, which preoperative factor is most associated with an increased risk of capsular contracture following breast augmentation. A. Implant placement in the subpectoral dual plane position. B. Periolar incision for implant placement. C. Textured implants instead of smooth implants. D. Preoperative antibiotic prophylaxis. Answer: B. Periolar incision for implant placement. Explanation: capsular contracture, a common complication of breast augmentation, is associated with bacterial contamination and inflammatory responses leading to excessive scar tissue around the implant. The periolar incision has been linked to a higher risk of capsular contracture due to the proximity of the incision to the breast ducts, which harbor bacteria. Option is incorrect. Subpectoral dual plane implant placement reduces the risk of capsular contracture compared to the subglandular position. Option C incorrect. Textured implants are associated with a lower risk of capsular contracture compared to smoother implants. Option D incorrect. Preoperative antibiotics help reduce the risk of infection but do not directly influence capsular contracture risk. Relevant guidelines: the American Society of Plastic Surgeons (ASPS) recommends inframammary incisions as the preferred approach to minimize capsular contracture. The Baker classification is used to grade capsular contracture severity. Question 6. Scenario-based. Topic: hand surgery, nerve repair. Dr. Thompson, the plastic surgeon, is called to evaluate a 40-year-old factory worker who sustained a deep laceration to the volar aspect of his forearm from an industrial blade. The patient reports numbness in the thumb, index, and middle fingers, along with difficulty flexing these digits. On physical examination, there is loss of opposition of the thumb and weakness in wrist flexion. Based on the injury pattern, which nerve is most likely affected and what is the best surgical approach? A. Radial nerve. Perform primary neuropathy with tension-free repair. B. Median nerve. Perform primary neuropathy or nerve grafting if tension is present. C. Ulnar nerve. Perform decompression and transposition to prevent long-term dysfunction. D. Superficial branch of the radial nerve. Conservative management with splinting. Answer: B. Median nerve or perform primary neuropathy or nerve grafting if tension is present. Explanation: the median nerve controls thumb opposition, wrist flexion, and sensation in the lateral three and the half fingers. A deep volar laceration is likely to sever the median nerve, necessitating immediate repair. Primary neuropathy is ideal if the nerve ends can be approximated without tension. Otherwise, nerve grafting, e.g. with sural nerve, is required. Optional incorrect. The radial nerve primarily controls wrist and finger extension. The described symptoms indicate median nerve injury. Option C incorrect. The ulnar nerve injury would affect the fourth and fifth digits, not the thumb and index fingers. Option D incorrect. The superficial radial nerve is sensory only and does not control motor function, so splinting alone is inadequate. Relevant guidelines: American Society for Surgery of the Hand ASH guidelines recommend primary repair or grafting for median nerve injuries to restore function. Early nerve repair improves functional outcomes, while delayed repair may require tendon transfers. Question 7. Topic: Microsurgery. Free flap reconstruction. A 58-year-old man with a history of radiation therapy for oropharyngeal cancer undergoes a radial forearm free flap for soft tissue reconstruction of the oral cavity. On postoperative day 2, the flap appears dusky and capillary refill is sluggish. Doppler ultrasound reveals diminished arterial inflow, which is the most appropriate next step in management. A. Administer systemic heparin to improve microvascular perfusion. B. Perform an urgent re-exploration of the anastomosis. C. Increase Roman fluids to optimize hemodynamic stability. D. Apply external warming measures to the affected flap. Answer: B. Perform an urgent re-exploration of the anastomosis. Explanation: early identification of vascular compromise is critical in free flap surgery. A dusky appearance and sluggish capillary refill suggest arterial thrombosis or anastomotic failure. Urgent surgical re-exploration is necessary to assess and revise the anastomosis, ensuring adequate blood flow. Optional incorrect. Systemic heparin may be helpful in venous congestion but is not the primary intervention for arterial insufficiency. Option C incorrect. Increasing Roman fluids does not address the underlying vascular occlusion. Option D incorrect. External warming is not effective in reversing arterial compromise. Relevant guidelines: the American Society of Reconstructive Microsurgery ASM recommends flap monitoring every 2 hours in the first 72 hours postoperatively. Early re-exploration within 6 hours of flap compromised significantly improves salvage rates. Question 8. Topic: Craniofacial surgery. Cleft lip and palate repair. 3-month-old infant presents with unilateral complete cleft lip and palate. The parents are concerned about the timing and sequencing of surgical interventions. You explain the principles of staged repair to optimize functional and aesthetic outcomes. What is the recommended timing for cleft lip and palate repair, and what is the most common long-term complication of cleft surgery? A. Cleft lip repair at 3 months, cleft palate repair at 6-1-2 months. Velopharyngeal insufficiency. B. Cleft lip repair at 6 months, cleft palate repair at 1-1-8 months. Maxillary retrusion. C. Cleft lip repair at 9 months, cleft palate repair at 2 years. A speech delay. D. Cleft lip and palate repair simultaneously at 6 months. Recurrent palatal fistula. Answer: A. Cleft lip repair at 3 months, cleft palate repair at 6-1-2 months. Velopharyngeal insufficiency. Explanation: the rule of 10 weeks old, 10 pounds hemoglobin of 10 is used to determine the timing of cleft lip repair, while cleft palate repair is typically done between 6-1-2 months to promote normal speech development. The most common long-term complication of cleft palate repair is velopharyngeal insufficiency, VPI, leading to hypernasal speech and nasal regurgitation. Option B incorrect. Maxillary retrusion occurs later in adolescence due to palatal scarring but is not the most common issue. Option C incorrect. Delaying cleft palate repair to 2 years increases the risk of speech delays. Option D incorrect. Simultaneous repair increases wound healing complications and fistula risk. Relevant guidelines: The American Cleft Palate Craniofacial Association (ACPAC) recommends early cleft palate closure to minimize speech and feeding complications. Question 9. Topic: Facial trauma. Zygomatocomaxillary compact VSE fractures. 26-year-old male presents to the emergency department after motorcycle accident. He has flattening of the right cheek, diplopia on upward gaze, and numbness over the infraorbital region. CT scan confirms right zygomatocomaxillary compact ZMC fracture with displacement. What is the primary goal of surgical treatment for this injury? Which approach provides the most comprehensive access to the fracture? A. Restore mid-face projection, a bicoronal approach. B. Re-establish zygomatic position, a Gillies approach. C. Address diplopia, transconjunctival approach. D. Correct infraorbital nerve injury, intraoral approach. Answer: A. Restore mid-face projection, a bicoronal approach. Explanation: the primary goal of VMC fracture repair is restoring mid-face projection and symmetry by reducing and fixing the displaced zygoma. The bicoronal approach provides the most comprehensive access to the zygomatic arch, orbital rim, and frontal processes, allowing for precise fracture reduction. Option B, incorrect. The Gillies approach is useful for closed reduction but does not allow for rigid fixation. Option C, incorrect. The transconjunctival approach is primarily for orbital floor fractures, CSC fractures. Option D, incorrect. The intraoral approach provides access but is inadequate for compact CMC fractures. Relevant guidelines. The craniomaxillofacial classification outlines optimal surgical exposure for facial fractures. Question 10. Topic: Breast reconstruction. Deep flap. 50-year-old woman undergoes delayed deep inferior epigastric perforator deep flap reconstruction following mastectomy for breast cancer. On postoperative day 1, the flap appears venously congested with bluish discoloration and capillary refill 4 seconds. What is the most likely cause and what is the appropriate management? A. Arterial thrombosis. Perform urgent re-exploration with revision of the anastomosis. B. Venous congestion due to inadequate outflow. Consider thrombectomy and revision of venous anastomosis. C. Ischemic reperfusion injury. Administer systemic heparin and hyperbaric oxygen therapy. D. Seroma formation. Aspirate and monitor closely. Answer: B. Venous congestion due to inadequate outflow. Consider thrombectomy and revision of venous anastomosis. Explanation: venous congestion is more common than arterial thrombosis in free flap failure and presence with dark, congested flaps with slow capillary refill. Urgent re-exploration with possible thrombectomy or venous anastomosis revision is required to restore blood flow and prevent flap necrosis. Option was incorrect. Arterial insufficiency leads to a pale, cold flap with no capillary refill. Option C, incorrect. Ischemia reperfusion injury occurs but does not cause early venous congestion. Option D, incorrect. Seroma does not cause flap congestion. Relevant guidelines. American Society of Reconstructive Microsurgery re-exploration within 6 hours significantly improves flap salvage. Question 11. Topic: Abdominoplasty. Complications. 42-year-old woman undergoes full abdominoplasty with liposuction for body contouring. On postoperative day 5, she develops increasing pain, erythema, and dusky area along the lower abdominal incision. Examination reveals skin necrosis with wound dehiscence. Which of the following is the most significant risk factor for this complication? A. Obesity. BMI 35 kilograms. B. Smoking history. C. Liposuction in the supraumbilical region. D. Use of progressive tension sutures. Answer: B. Smoking history. Explanation: smoking is the strongest modifiable risk factor for wound healing complications in abdominoplasty due to its impact on microvascular circulation and oxygenation. Option when correct. Obesity increased DVT risk but is less significant for skin necrosis than smoking. Option C, incorrect. Supraumbilical liposuction may compromise vascular supply but is not the primary cause of necrosis. Option D, incorrect. Progressive tension sutures decrease the risk of seroma and do not contribute to necrosis. Relevant guidelines. The American Society of Plastic Surgeons (ASPS) recommends smoking cessation for at least 4-6 weeks preoperatively. Question 12. Topic: Hand surgery. Flexor tendon repair. 30-year-old construction worker sustains zoonomentixer tendon laceration after glass injury. You perform primary flexor tendon repair using 4-strand core suture technique with an epitendinous repair. What is the most critical factor in preventing postoperative adhesions and maximizing tendon gliding? A. Passive motion rehabilitation with early controlled therapy. B. Avoiding coarse sutures to minimize bulk. C. Delaying active movement for 6 weeks. D. Using locking loop suture technique instead of 4-strand repair. Answer: A. Passive motion rehabilitation with early controlled therapy. Explanation: early controlled passive motion therapy, such as the Kleiner or Durham protocols, prevents adhesions and enhances tendon gliding. Option B incorrect. Coarse sutures are necessary for strength and gap resistance. Option C incorrect. Delaying motion increases adhesion formation. Option D incorrect. Locking loop techniques improve suture strength but do not prevent adhesions. Relevant guidelines: the American Society for Surgery of the Hand (ASH) emphasizes early motion therapy for Zun, Rome, and Torres. Question 13. Topic: Craniofacial surgery. Mandibular distraction osteogenesis. 6-month-old infant with Pierre-Robin sequence (PRS) has severe airway obstruction despite prone positioning and nasopharyngeal airway placement. Polysomnography confirms severe obstructive sleep apnea (OSA). Which of the following surgical interventions is most appropriate? A. Tracheostomy. B. Mandibular distraction osteogenesis (MDO). C. Tonsillectomy and adenoidectomy. D. Tongue lip adhesion (TLA). Answer: B. Mandibular distraction osteogenesis (MDO). Explanation: MDO lengthens the mandible to advance the tongue base and improve airway obstruction in PRS. Option was incorrect. Tracheostomy is effective but reserved for failure of less invasive options. Option C incorrect. PRS is not caused by tonsillar hypertrophy, so T is ineffective. Option D incorrect. TLA may be used but is less effective than MDO. Relevant guidelines: the American Cleft Palate Craniofacial Association (ACPAT) recommends MDO for severe PRS airway obstruction. Question 14. Topic: breast augmentation. Capsular contracture. 35-year-old woman undergoes subglandular breast augmentation with smooth silicone implants. 3 years later, she presents with firmness, distortion, and pain in her left breast. Examination reveals Baker-grade Rome contracture. What is the most effective treatment? A. Capsulectomy with implant exchange and conversion to submuscular placement. B. Closed capsulotomy manual compression technique. C. Oral leukotriene inhibitors. E. G. Montelukast. D. Aspiration and intralesional steroid injection. Answer: A. Capsulectomy with implant exchange and conversion to submuscular placement. Explanation: total capsulectomy with implant exchange and conversion to a submuscular position significantly reduces recurrence risk. Option B incorrect. Closed capsulotomy is no longer recommended due to implant rupture risk. Option C incorrect. Leukotriene inhibitors are controversial with limited efficacy. Option D incorrect. Aspiration and steroids do not resolve contracture. Relevant guidelines: the ASPS recommends capsulectomy for Baker-grade Rome contractures. Question 15. Topic: microsurgery. Free flap salvage. 55-year-old woman undergoes free fibular flap for mandibular reconstruction. On postoperative day 2, the flap appears dusky with absent Doppler signals. What is the next best step? A. Immediate return to the or for exploration. B. Administer omen heparin and monitor for improvement. C. Increase omen UIDs and elevate the flap. D. Start hyperbaric oxygen therapy. Answer: A. Immediate return to the or for exploration. Explanation: free flap failure must be addressed within 6 hours to optimize salvage. Option B incorrect. Heparin delays necessary intervention. Option C incorrect. Increasing fluids does not resolve thrombosis. Option D incorrect. Hyperbaric oxygen cannot restore lost vascularization. Relevant guidelines: the ASAM emphasizes early surgical intervention for vascular compromise. Question 16. Topic: aesthetic surgery. Rhinoplasty. Patient undergoes primary open rhinoplasty for nasal dorsum reduction. Postoperatively, she has persistent nasal obstruction and valve collapse. What is the best reconstructive option? A. Spreader grafts. B. Osteotomies. C. Tip suturing techniques. D. Inferior turbinate reduction. Answer: A. Spreader grafts. Explanation: spreader grafts reconstruct the internal nasal valve to improve airflow. Option B incorrect. Osteotomies correct dorsal asymmetry, not valve collapse. Option C incorrect. Tip suturing does not address valve dysfunction. Option D incorrect. Turbinate reduction does not correct collapse. Relevant guidelines. The Rhinoplasty Society recommends spreader grafts for valve collapse. Question 17. Topic: facial trauma. Orbital fractures. 35-year-old male presents after motor vehicle collision with periorbital ecchymosis in ophthalmos and restricted upward gaze. CT scan reveals an orbital floor fracture with entrapment of the inferior rectus muscle. Which of the following is the most appropriate next step? A. Immediate surgical repair within 24 hours. B. Observation and follow-up in 2 weeks. C. Oral corticosteroids and ice application. D. Surgical repair within 2 weeks if symptoms persist. Answer A. Immediate surgical repair within 24 hours. Explanation: entrapment of the inferior rectus muscle with restricted eye movement requires urgent surgery to prevent permanent fibrosis and diplopia. Option B incorrect. Observation is appropriate only for non-trapped fractures. Option C incorrect. Steroids reduce swelling but do not resolve entrapment. Option D incorrect. Delaying surgery increases muscle fibrosis risk. Relevant guidelines. The American Society of Ophthalmic, Plastic and Reconstructive Surgery (ASOPUS) recommends early repair for muscle entrapment. Question 18. Topic: hand surgery. Replantation criteria. 28-year-old factory worker sustains complete amputation of the index finger at the pip joint from machine accident. There is minimal crush injury and no significant contamination. Which of the following best predicts successful replantation outcome? A. Patient's smoking history. B. Warm ischemia time under 6 hours. C. Age of the patient. D. Preservation of venous outflow. Answer D. Preservation of venous outflow. Explanation: successful replantation requires arterial inflow and venous outflow to prevent venous congestion and failure. Option was incorrect. Smoking affects healing but is not the primary determinant. Option B incorrect. Warm ischemia time is important but venous patency is more critical. Option C incorrect. Age impacts healing but is not the strongest predictor of relevant guidelines. The American Society for Surgery of the Hand (ASH) prioritizes venous drainage for replant success. Question 19. Topic: microsurgery. Alt versus deep flap. 45-year-old woman undergoes delayed breast reconstruction. She has history of multiple abdominal surgeries, making deep flap potentially challenging. What is the best alternative free flap option? A. Latissimus dorsi flap. B. Anterolateral thigh alt flap. C. Superior gluteal artery perforator SCAP flap. D. Tram flap. Answer B. Anterolateral thigh alt flap. Explanation: the alt flap is a versatile free flap with low donor site morbidity and is preferred when the abdomen is not available. Option is incorrect. Latissimus dorsi flap is a pedicled flap and often requires an implant. Option C incorrect. SCAP flap is technically more complex than alt. Option D incorrect. Tram flap has higher donor site morbidity. Relevant guidelines. The American Society of Plastic Surgeons (ASPS) supports alt as an alternative to abdominal-based flaps. Question 20. Topic: cleft lip repair. Timing: newborn is diagnosed with unilateral cleft lip and alveolus. The parents ask about the optimal timing for surgical repair. What is the most appropriate response? A. Repair at birth to optimize feeding. B. Repair at 1-2 weeks of age. C. Repair at 3-6 months of age. D. Repair at 1-18 months of age. Answer C. Repair at 3-6 months of age. Explanation: cleft lip repair follows the rule of tens. At least 10 weeks old, at least 10 pounds hemoglobin, 10 grams. Still relevant guidelines. The American Cleft Palate Craniofacial Association (ACPA) recommends lip repair at 3-6 months. Question 21. Topic: breast reduction. Insurance criteria. 38-year-old woman presents for bilateral breast reduction due to chronic neck and back pain. Which of the following is most important for insurance coverage? A. Surgeon's recommendation. B. Patient-reported symptoms. C. Wake of breast tissue to be removed. D. MRI findings of spinal compression. Answer C. Weight of breast tissue to be removed. Explanation: insurance companies require a minimum weight of tissue removal, typically 500 grams per breast. Relevant guidelines. The ASTS criteria for insurance coverage include breast weight and failed conservative therapy. Question 22. Topic: facelift. SMOS techniques. 55-year-old woman undergoes rhytidectomy. The surgeon plans deep plane facelift to improve mid-face sagging and jowls. Which of the following best describes this technique? A. Skin-only elevation with no SMOS manipulation. B. Plication of the SMOS without skin undermining. C. Release of retaining ligaments and repositioning of the SMOS. D. Subperiosteal dissection along the zygoma. Answer C. Release of retaining ligaments and repositioning of the SMOS. Explanation. A deep plane facelift involves releasing retaining ligaments to mobilize and reposition the SMOS layer. Relevant guidelines. The American Academy of Facial Plastic and Reconstructive Surgery considers deep plane techniques superior for natural mid-face rejuvenation. Question 23. Topic: Skin cancer. Most verses. Excision: 70-year-old patient with BCC on the nasal tip is considering treatment options. What is the best reconstructive approach? A. Simple elliptical excision. B. Mohs micrographic surgery with local flap closure. C. Radiation therapy. D. Cryotherapy. Answer: B. Mohs micrographic surgery with local flap closure. Explanation. Mohs surgery offers tissue sparing and high cure rates, making it ideal for cosmetically sensitive areas. Relevant guidelines. The American College of Mohs Surgery (ACOMS) recommends Mohs for fail EE. Question 24. Topic: Burns. Fluid resuscitation. 45-year-old man sustains 40% TBSA burns. He weighs 80 kilograms. Using the Parkland formula, weighs his fluid requirement in the first 8 hours. A. 2400 ml. B. 6,400 ml. C. 12,800 ml. D. 19,200 ml. Answer: B. 6,400 ml. Explanation. Parkland formula. 4A G% Sodalewals 4 KTX equals 12,800 ml first 8 equals 6,400 ml. Relevant guidelines. The American Burn Association (ABAT) recommends lactated ringers using the Parkland formula. Question 25. Topic: Craniosynostosis. Surgical timing. 6-month-old male infant presents with an abnormal head shape. Physical examination reveals frontal bossing, biparietal narrowing, and boat-shaped skull consistent with sagittal craniosynostosis. Which of the following is the most appropriate timing for surgical intervention? A. Before 3 months of age. B. Between 1-2 months of age. C. After 18 months of age. D. Only if the patient develops increased intracranial pressure. Answer: B. Between 1-2 months of age. Explanation. Craniosynostosis surgery is typically performed between 1-2 months, allowing for maximal skull remodeling while minimizing surgical risks. Option incorrect. Surgery before 3 months is rare due to the risk of excessive blood loss. Option C incorrect. After 18 months, skull rigidity limits surgical correction. Option D incorrect. Symptoms may not appear initially, but early intervention prevents future complications. Relevant guidelines. The American Cleft Palate Craniofacial Association (ACPAT) recommends early surgical intervention for single suture synostosis. Question 26. Topic: Peripheral nerve surgery. Brachial plexus injury. 28-year-old motorcyclist presents with loss of shoulder abduction, elbow flexion, and wrist extension after high-speed crash. MRI shows a CC nerve root avulsion. Which of the following is the best surgical option for functional recovery? A. Primary nerve repair. B. Nerve grafting. C. Nerve transfer. G. Oberlin transfer. D. Tendon transfer. Answer: C. Nerve transfer. G. Oberlin transfer. Explanation. For proximal nerve root avulsion, C. Nerve transfers. G. Oberlin transfer provide the fastest and most functional recovery. Option incorrect. Primary repair is not possible in root avulsion. Option B incorrect. Nerve grafting is less effective for root avulsion compared to transfers. Option D incorrect. Tendon transfers are used later if nerve recovery is inadequate. Relevant guidelines. The American Society for Surgery of the Hand supports early nerve transfer over nerve grafting for root avulsions. Question 27. Topic: Breast augmentation. Implant complications. 34-year-old woman presents with asymmetry and pain in her right breast 5 years after silicone breast augmentation. MRI reveals implant rupture. Which of the following is the best next step? A. Close monitoring without intervention. B. Ultrasound-guided aspiration of silicone. C. Removal of the ruptured implant with capsulectomy. D. Implant replacement with no further intervention. Answer: C. Removal of the ruptured implant with capsulectomy. Explanation. Silicone implant rupture requires surgical removal, often with total capsulectomy, to prevent chronic inflammation, silicone granulomas. Optional incorrect. Monitoring is inappropriate due to symptoms. Option B incorrect. Aspiration is not effective for silicone removal. Option D incorrect. Implant replacement without capsulectomy may worsen complications. Relevant guidelines. The FDA and AST recommend MRI surveillance every 3 years for silicone implants and removal if rupture occurs. Question 20. Topic: Skin grafting. Split versus full thickness grafts. 70-year-old male with non-healing venous ulcer on the medial ankle undergoes split thickness skin grafting (SG). Which of the following best explains why CSG is preferred over full thickness skin grafts (FSG) in this case? A. CSG provides superior cosmetic outcome. ESG has higher take rate on poorly vascularized wounds. C. SCSG has reduced donor site morbidity. E. SCSG is more resistant to contracture. Answer: CSESG has reduced donor site morbidity. Explanation: SESG requires less vascularization, adheres more easily, and causes less donor site morbidity. Option when incorrect. SESG provides better cosmetic outcomes than SESG. Option B incorrect. SESG still requires vascularization, but its thinner nature allows better adherence. Option D incorrect. SESG resists contracture better than SESG. Relevant guidelines. The American Burn Association (ABA) supports SSG for chronic wounds due to better survival in suboptimal wound beds. Question 29. Topic: Abdominal wall reconstruction. Hernia repair. 56-year-old male with history of prior laparotomies presents with 10 cm wide incisional hernia with loss of domain. Which of the following is the best reconstructive approach? A. Primary closure with mesh reinforcement. B. Component separation with biologic mesh. C. Tension-free suture repair. D. Laparoscopic repair. Answer: B. Component separation with biologic mesh. Explanation: large hernias, 10 cm, with loss of domain require component separation to restore abdominal wall function. Optional incorrect. Primary closure is not feasible for large hernias. Option C incorrect. Tension-free suture repair fails in large defects. Option D incorrect. Laparoscopic repair is not effective for massive defects. Relevant guidelines. The American Hernia Society (AS) recommends component separation for hernias 810 cm. Question 30. Topic: Pediatric burn management. Fluid resuscitation. 2-year-old child sustains 30% IBSA burns. The child weighs 12 kilograms. Using the Parkland formula, how much fluid should be given in the first 8 hours? A. 720 ml. B. 1440 ml. C. 2880 ml. D. 3600 ml. Answer: B. 1440 ml. Explanation: Parkland form equals with G% so total equals 4x 12x equals 1440 ml first 8 hours. Option incorrect. Underestimates fluid needs. Option C incorrect. Overestimates fluid needs. Option D incorrect. Too much fluid can cause fluid overload. Relevant guidelines. The American Burn Association (ABA) recommends lactated ringers using the Parkland formula for burns 20% IBSA.